karya kala chahi hamka dekhle hamka penyuri hamka dekhle kama tuma dekhle dekhle hamka penyuri hamka dekhle kama tuma dekhle.
Hello, this is Dr. Fakir Raveri. Welcome to this presentation on systematic reviews and meta-analysis. Our first learning objective is distinguish between a narrative review, a systematic review, and a meta-analysis. Review articles give an overview of existing literature in a field. They often identify specific problems or issues and analyze information from available published work on the topic with a balanced perspective. Generally speaking, review articles can be of three types: either a narrative review, a systematic review, or a meta-analysis. Narrative reviews often include a discussion of one or more aspects of disease etiology, diagnosis, or treatment. They tend to be mainly descriptive. They do not involve a systematic search of the literature, often focus on a subset of studies in an area chosen based on availability or author selection. They can often include elements of selection bias, so it's based off what articles the author selects to talk about in the review article. They can be confusing at times if similar studies have diverging results and conclusions. Systematic reviews, on the other hand, a systematic review is a summary of research that attempts to address a focused clinical question in a systematic, reproducible manner. As the name implies, systematic reviews typically involve a detailed and comprehensive plan and search strategy derived a priori with the goal of reducing bias by identifying, appraising, and synthesizing all relevant studies on a particular topic. Although systematic reviews are published in journals, there are also organizations and databases specifically developed to promote and disseminate them. So the most common example is the Cochrane collaboration, which are available on their website. A meta-analysis is a statistical pooling or aggregation of results from different studies to provide a single best estimate of effect. And effect is referring to the outcome that they're looking for. So if there's a specific question and they're asking, for example, what's the mortality rate based on a specific drug, and then the effect is really that mortality that they're looking for. It could be anything that they're looking at, but really in general, we refer to it as effect. So when the treatment effect or effect size is consistent from one study to the next, meta-analysis can be used to identify this common effect. When the effect varies from one study to the next, meta-analysis may be used to identify the reason for the variation. Now, in general, a meta-analysis can be combined with other types of reviews. The most common type is a systematic review and meta-analysis. Most systematic reviews combine the results of the studies statistically. Hence, most systematic reviews contain a meta-analysis, and hence the common usage of titles like a systematic review and meta-analysis. However, there can be reviews that are just meta-analysis but not a systematic review. So, for example, a meta-analysis can just combine the results of a few studies, but those studies may not have been systematically selected. So an author can choose, let's say 8 or 10 studies and combine the results in a meta-analysis. Such a study would just be a meta-analysis but not a systematic review and meta-analysis. And there are also reviews that are just a systematic review but not a meta-analysis. So, the author would just systematically identify review articles and present them, but not combine the results. There are advantages and disadvantages of doing a meta-analysis. Advantages of meta-analysis include increased power or strength from combining results from several studies, more conclusive results even if individual studies were not conclusive, and greater generalizability due to larger and possibly more diverse population. Some limitations include publication bias. So, because positive results are more likely to be published, in other words, if a study finds what they're looking for, they are more likely to be published in journals. Whereas, if a study is comparing two groups and they don't find a difference, uh, it's more likely that those studies will not be published in a journal because they didn't really find anything. So if someone is doing a meta-analysis of multiple studies and they're combining studies that are published, that's referred to as publication bias because they can only see the studies that are published, and because those studies are typically positive results as opposed to negative results, that could be a limitation of meta-analysis. Meta-analysis based on published trail could lead to false positive. So they should include unpublished data. So there are ways to contact, for example, whether it's the manufacturer that conducted the studies or other organizations. So the authors really should seek and get those unpublished data and include them in their meta-analysis to avoid publication bias. There are also issues related to combining. So combining dissimilar studies could lead to misleading results. Why should we seek systematic reviews? There are several reasons. So single studies are liable to be unrepresentative of the total body of evidence, and the results may therefore be misleading. Collecting and appraising a number of studies take time you probably do not have. A systematic review is often accompanied by a meta-analysis to provide the best estimate of effect that increases precision and facilitates clinical decision making. So that's good. If the systematic review is performed well, it will likely provide all of the relevant evidence with an assessment of the best estimates of effect and the confidence they warrant. Systematic reviews include a greater range of patients than any single study, potentially enhancing your confidence in applying the results to the patient before you. So these are really good reasons for looking for a systematic review when you have a clinical question that you're looking for the answer to. Now here's a table to compare narrative review to systematic review. The topics are generally broad in the narrative review versus there's a focused research question in systematic review. You may have heard the term PICO. So really PICO is what is used to come up with a focused question that they are answering when using systematic review, and that's not necessarily the case with narrative review. So the data sources and search strategies are not explicitly described in narrative review, so the author may select, just some articles that to talk about. Whereas in systematic review, there are explicitly described how they came up with the articles that they reviewed. Authorship usually in narrative reviews is an expert in the field. It could be a single person or two or three persons who together write the article. Whereas in a systematic review, you have a team of experts having methodological and clinical expertise. Article selections typically not specified in narrative reviews, but there are inclusion-exclusion criteria for choosing those articles in a systematic review. When it comes to searching the literature, there may be extensive or intended to locate literature on the topic of interest in narrative review, whereas in systematic review, there's extensive intended to locate all primary studies on a particular research question. And with these are usually reproducible. So if you use their search criteria, you typically come up with the same studies because they are very specific to what search keys they used and how they included and excluded some of those studies. Appraisal is not always present in narrative review, whereas in a systematic review there needs to be critical appraiser appraisal. So what that means is that what all the studies that are included in the systematic review, they will actually grade the quality of those studies and will tell you if these are strong evidence or low quality evidence. And they can also, based on their exclusion criteria, they can choose to exclude studies that are low quality to improve the confidence in the outcomes they find. For synthesis, a qualitative summary is usually provided. In systematic reviews, a qualitative summary is provided, and also a quantitative when the data can be pulled. So that means if they also do a meta-analysis, there's also a quantitative um, results or summary present when they combine all the data from the studies, which is not present in the narrative review. When you extrapolate from these reviews, sometimes this can be evidence-based in narrative review. Other times it can be the opinion of the author. Whereas in systematic reviews, it's usually evidence-based and not the opinion of the authors. So narrative reviews are, good for background information. So if you're, trying to get familiar with a topic, narrative reviews are good. And systematic reviews are good for clinical evidence. So the systematic reviews are really good if you are to make a recommendation for a patient. Now let's take a look at a few examples. Let's take a look at the example of a narrative review. So the first one is the effect of vitamin D status on the risk factors for cardiovascular disease, published in Nature Reviews Nephrology in 2013. So here's the article. So you can see it is a review article, and it has the title and then the authors, and then there's an abstract so a summary of the article. So if you browse through this article, you see there's an introduction section. So it gives you some background about vitamin D, and then if you keep browsing, they give you some key points of what the article is trying to communicate. There's a box with classification of vitamin D deficiency. And then if you keep going, then they talk about pathways involving vitamin D. So basically pathophysiology. So, there was an introduction, then pathophysiology. They have a picture for pathophysiology. And then if you keep browsing through, there's still pathophysiology. Then they talk about epidemiology. Um, let's see, more epidemiology, and then they talk about some clinical trials. So they start with talking about the double-blind randomized controlled trial. So they give you the summary of what they found as far as inflammation. Then they get to hypertension. They refer to a systematic review and meta-analysis, and they talk about what they found in that study. And they give you the reference here. So they're referring to another study, not that this is a meta-analysis and systematic review, but they're just they chose the study and they're talking about it. And then they go to chronic kidney disease. So really, they're just giving you information here, and then you get to conclusions. So then they come up with conclusions, and they have their references, right? So although they do give you review criteria, so they say this review was based on a search of the PubMed database using search terms, no data or language restrictions, so they tell you how they searched PubMed to find some of their studies, but they don't really tell you how they selected. So once you run these keywords, you will get a lot of studies, right? They didn't tell you how they selected them. They didn't have inclusion exclusion criteria, and they didn't really grade those studies that they talked about. So they didn't say how strong the evidence was, right? So this is an example of narrative review. So the authors talked about the topic, right? Vitamin D status and risk factor for cardiovascular disease, right? And they talked about etiology, epidemiology, some of the clinical trials, and conclusion, right? So this is not a systematic review and certainly not a meta-analysis. So this is a narrative review. Let's take a look at another example. So the next one is a review of hypertension, which was published in the Lancet in 2015. So here's what the article looks like. So hypertension, here's the title. They call it a seminar in the Lancet. And so here are the authors and then the abstract or the summary. So they start by epidemiology. So they give you some epidemiology about hypertension. Um, Here on first page, they tell you the search strategy and selection criteria. So they said, okay, they searched Medline on PubMed. From this day, with this search with these keywords, and then we searched the identified articles for additional studies. We filtered on quality and influence. The reference list was modified on the basis of comments from peer reviewers. So although they have some search strategy, but this is not a systematic review because they didn't really give you inclusion and exclusion criteria for choosing the studies that they found. And they certainly don't, they're not really grading the studies that they find. So they don't tell you the quality of evidence that they're including. So these authors selected, a few studies that they liked to talk about hypertension. So epidemiology first, then they went to pathophysiology. Let's see what else. Pathophysiology, then they go to diagnosis, um, some comorbidities, and then management or treatment of hypertension, right? So they talk about diet and lifestyle. Um, they refer to some guidelines. They're comparing different guidelines. You don't have to worry about this. I'm just giving you an example of narrative review. And then pharmacotherapy of hypertension. Um, and they talk about prevention. After they talk about treatment, then they talk about prevention, and then um, they give you some recommendations. So really, this is not a systematic review and certainly not a meta-analysis. So what this is a narrative review. Next example is of an actual systematic review. So this article is called Firearm Laws and Firearm Homicides, a systematic review that was published in JAMA Internal Medicine in 2017, so just recently. And here's what they found. So as you can see in the title, it says it is a systematic review, right? And then they have the author names, and then here's the abstract basically. So here, note that the abstract is a little different than the previous ones. So the narrative review is just a summary. Now they're telling you, there's an objective, so to evaluate the association between firearm laws and preventing firearm homicide in the United States. Then they tell you how they review the evidence. So they tell you, uh, you know, evaluate peer-reviewed articles from this time period. They search these databases. Uh, they divide them into different categories. The articles were assessed using the standardized guide to community preventive services data collection. So they did assess now they're appraising the data. So it's not just randomly selecting studies, but they're actually appraising the studies. And 5 additional quality metrics. So they use all these metrics to choose the studies that they found. And then they give you a conclusion, right? So that was all abstract, and then you can go into the actual study. So they give you some background, they give you a summary of what they actually found in the study here. Here's a map, and here's what's really important. So here's how you know it's a systematic review. So they're telling you how they selected articles. So they saying they found about 2,000 records through database searching, and they found 9 additional through other sources for a total of 1,582 records, right? Then they screened based on their inclusion exclusion criteria, and they ended up with 34 studies. So it's a very systematic way of choosing 34 studies. It's not randomly selecting 34 studies. And they have a method section, so they tell you exactly how they searched the literature, so don't worry too much about the details, but the important is that they're telling you exactly how they searched. Then they're telling you how they evaluated in individual studies, and they also give you the studies in table 2. So um, let's see, table 2. Here's table 2. So here are all the studies that they included. They tell you how they assess the quality of the studies. Let's see what else. So, they have a systematic way of approaching this. That's what makes it a systematic review and not a narrative review. Uh, and then at the end they tell you about the limitations and then a conclusion, right? Followed by references. So this is a good example of a systematic review, and they didn't do a meta-analysis, right? So while they found individual studies, they didn't combine the results of those studies. Okay, now let's take a look at an example of a meta-analysis. So this is an example of a meta-analysis. So they're talking about beta-lactam, beta-lactamase inhibitor. Don't worry about what this is. So this is basically a class of drug. So what they're trying to find is that if we use this class of drug for treatment of bacteremias or infection in the blood, basically, they're trying to see um, what we can find, right? So don't worry about what they're what these all of these means. So basically, they're trying to see, if you use a certain class of drug to treat infections in the blood, what are we going to find out, right? So again, so here's the title, and here are the authors. And note that the abstract is also, kind of looks like systematic review. So it's not just a summary, but they tell you the background, methods, results, and conclusions. So that's the abstract. And then if you keep scrolling, there's background information, and then for methods, they tell you how the study, what kind of studies they were looking at, because they're looking for certain patient population, right? So for example, they're trying to treat infection in the blood. So they looked at studies with patients who had infection in the blood. So that's what they did, but they didn't really tell you, how they're gonna grade the individual studies. So that's why this is not a systematic reviews. This is not a systematic review, but it's just a meta-analysis. So what they found is when they found those individual studies, they actually combined the results. They've combined the results to get a really, really big study. So because the individual studies were really small, they combined them to get one big study. So here in table 1 they tell you, so they found 6 studies. They found 6 studies, not systematically, so they just found 6 studies that met the patients that they were looking for. So they have listed 1, 2, 3, 4, 5, 6 studies. So they tell you like what year those studies looked at patients, right? And then they tell you how many patients were in the studies. And then they combine them. So they tell you the total, they found these many patients. So once they combined all the information from these 6 studies, then they actually uh, the meta-analysis, and they found specific outcomes as a whole. Don't worry too much about the details of what they found, but just what's important is that they found 6 studies and they combined all the information. So that's what a meta-analysis is. You combine information from individual studies to get one giant study. So there are also systematic reviews and meta-analysis. So I just show you a couple of examples. So this one is looking at massage therapy for essential hypertension, which calls it a systematic review. So you may think from the title that this is just a systematic review and not a meta-analysis. But if you keep looking at it, so here's the abstract. So although the abstract may look like just a simple summary, but they do give you like a little background and they tell you like their methods. Then they tell you what they found, and then they give you their conclusion. So this is a systematic review. So they give you some introduction. They tell you methods. So they tell you, their search strategy, inclusion criteria. Um, then they tell you um, quality assessment. So they did inclusion criteria, search strategy, and they assess the quality of the individual study. So that's why this is a systematic review. And then they have a data synthesis. So they actually combine data. So that's why this is a meta-analysis also. So they combine, data from those individual studies. So if you keep going, so here's the figure that they show you how they found those studies systematically. So they ended up with 24 different studies, and then they included. See, now they tell you this is a meta-analysis. So they found 24 studies, and they combined the results of these 24 studies in a meta-analysis. So here they tell you in table 1, they have listed the different studies. And here's, I will talk about what these pictures are. These are called forest plots. So you can see they include different studies, and they include they add the actual results to get the total. So here you can see the results of individual studies, and then they combine them to get the overall results. So that's what the meta-analysis is. So now they're looking at different outcomes. So then here's another outcome they're looking at. So they tell you the results of individual studies, and then they total. So they combine the results to get a meta-analysis. So don't worry too much about the details, but I just want you to see what a meta-analysis looks like. Here's another one. This one is binge eating disorder in adults. So here in the title, it actually tells you it's a systematic review and meta-analysis. So here are the authors, and then here's the abstract. So we know it's a systematic review because they tell you their search strategy, how they selected studies, and how they appraised it. See, they graded strength of evidence, so they actually appraised the studies included, and then data synthesis, so they combine studies to get the overall result. So that's how we know it is a um, meta-analysis. See, so they also give you forest plots too. So here are like individual studies. They tell you what the results of that individual study was, and then they combine. So then they tell you overall, here's what we found. So that's what the meta-analysis is. And because those studies were selected systematically, this is a systematic review and meta-analysis. Okay, I think that's enough examples. The next learning objective is, given a forest plot, interpret the results of a meta-analysis. So now let's take a look at what that forest plot is. A meta-analysis provides the best estimate of effect. So effect often called a summary or pooled estimate from the weighted averages of the results of the individual studies, like I mentioned. So the weighting process depends on the sample size or number of events, or more specifically, study precision. When applying research evidence to a clinical question, I should always determine whether clinical action would differ if the upper or lower boundaries of the confidence interval represents the truth. So if the clinical decision is the same whether the upper or lower boundaries of the confidence interval represents the true effect, then the evidence is sufficiently precise. So that's what they mean by precision. Now, if across the range of the confidence interval values our decision making would change, then we would have less confidence in the evidence and lower the confidence rating. Studies that are more precise have narrower confidence interval and larger weight in meta-analysis, and vice versa. So the studies that are less precise, they have a wide confidence interval and they have a smaller weight in meta-analysis. Now, when you look at outcomes in meta-analysis, there are two types of outcomes. One is a dichotomous outcome, and the other is continuous outcome. For so dichotomous outcome, basically these are yes/no questions. So, for example, when you look at mortality, the patient is either dead or alive, right? So you say, did the patient die? Yes, no. So these are the outcomes that you look at. So, if mortality is the outcome, that's an example of a dichotomous outcome. So in a meta-analysis of a therapeutic question looking at this kind of outcome, um, for estimate of the magnitude of the benefit or risk, you should look for relative risk or the odds ratio. Now, if when you analyze this using a time to event method, then you're looking at hazard ratio. So for yes no outcomes, look for either relative risk, odds ratio, or hazard ratio. For continuous outcomes, these are more complicated and don't look into too much details because dichotomous outcomes are more common because we look at did, for example, treatment, did it work, yes or no, or if you're looking at mortality, is the patient alive, yes or no. And then continuous outcomes are kind of like um, for example, the length of hospitalization, right? So if you're looking like how long were the patients in the hospital, and then it can be any number, right? So that's why it's continuous. So it could be, 4 days, 5 days, 6 days, 7 days, it could be anything. So it's not the exact yes or no answer. So these are a little more complicated and more difficult to conduct. And the other thing that makes it complicated, usually when you're combining the data, usually the units may not match. So, if you're combining several studies with continuous variables, each study may have used the different units, right? So because of that, it becomes more challenging to combine data. So one of the things that they can do is to use standard deviation, um, and that way you can make it a little easier to combine. Now let's take a look at forest plots. So forest plots show the effect or the result from every study. The point estimate is presented as a square with a size that is proportional to the weight of the study, and the confidence interval is presented as a horizontal line. The solid line at 1 indicates no effect. So if you're looking at the ratio, you don't want the confidence interval to cross 1. If it crosses 1, that means it's not statistically significant. If you're looking at difference, then you don't want it to cross 0. It crosses 0, that means it's not statistically significant. So generally speaking, if a study's 95% confidence interval touches or crosses over the vertical line, it is not statistically significant. So that line is either 1 if you're looking at ratios like hazard ratio or relative risk or odds ratio, or that line is 0 if you're looking at the difference. So if you're instead of a ratio, you're looking at the difference between the two groups, then you don't want to cross 0. And I say generally because these are, if you're looking at superiority studies, this is true. There is something referred to as non-inferiority studies, and that's the only exception where we can cross 1 and 0 and still be statistically significant. And non-inferiority studies is beyond the scope of this topic. So. The combined summary effect is usually presented as a diamond with its width representing the confidence interval for the combined effect. And as the confidence interval widens, uncertainty about the magnitude of effect increases. Now, when the confidence interval crosses no effect, there is uncertainty about whether the intervention has any effect at all. So here's an example of a forest plot. So everything is red is annotation that I put in there. So you can see there are different studies listed. So they have the author's name and the year it was published. So here's study 1, study 2, study 3, study 4, and study 5. And then this line here shows you the line of no effect. So because the outcome that they're looking at is odds ratio, so it's a ratio. So an odds ratio of 1 would mean that there is no difference between the two groups. So therefore they have this line as the line of no effect. And then on the x-axis they also have odds ratio of 2, 3, and then they have shown different studies. So for study 1, they say that in that study they found an odds ratio. So it doesn't matter what they were looking at or what the outcome was. Don't worry about that. I just want you to understand what this forest plot is showing. So they say study 1, for the outcome that they were looking at between the two groups, they found an odds ratio of 1.3. So this black square is showing the 1.3, and then there's a 95% confidence interval. So in the parenthesis here is showing that there's a 95% confidence interval from 0.5 to 2.6, and they have also plotted it. So they show this goes from 0.5, which is less than 1, right? So the confidence interval goes from 0.5 to 2.6. So because this confidence interval has crossed 1, this one study is not statistically significant. Now if you look at study 2, it says for the outcome that they're looking at between the two groups, there was an odds ratio of 2.1. So here's the square, and the size of the square shows the weight of that study depending on how many patients were in there and the quality of that study. So they're saying the odds ratio of 2.1 and the 95% confidence interval goes from 1 to 3.4. 3.4. So if you plot this, it's 1 to 3.4. And because 1 is touching the line of no effect, which is 1, so this one is also not statistically significant. Now, note that there are no p-values reported, and you didn't need the p-values because you could just use this confidence interval to decide whether that study was statistically significant. Now, when you look at study number 3, there's also a confidence interval from 0.9 to 3.2, so it also crosses 1, so it's not statistically significant. Now, if you look at study 4, the odds ratio is 2.3, and look how big this square is. So there's a bigger weight from this study, so it probably had more patients in the study, and the confidence interval goes from 1.9 to 2.7. So because the confidence interval did not cross 1, this one is statistically significant. And also note that the confidence interval is narrower, so this probably did have a lot more patients in it. So the more patients you have in a study, the narrower the confidence interval, because you're more confident that what you found in that study is, a true number. Now the last study, study 5, note that it has an even bigger square. So there were a lot more patients in this study, and they found the odds ratio of 2.1 with a 95% confidence interval going from 1.8 to 2.5. So again, this one didn't cross 1. So because of that, it is statistically significant. So you can see we have 3 studies that, they showed no difference, and 2 of them did. So that's why it's good to do meta-analysis. So they combined the results of these 5 studies, and they found an odds ratio of 2.2 with a 95% confidence interval of 1.9 to 2.4. So it goes from 1.9 is the edge of this diamond to 2.4, and because it did not cross 1, overall the results are statistically significant. So if someone was looking at a question and these studies were relevant to that question, if you came across the study 1, you would have concluded, oh, there's no difference. Or maybe study 3, you would say there's no difference. Or if you found study number 5, you would say, oh, there is a difference. Then that's confusing. So is there or is there not a difference? So when you do a meta-analysis, then you can conclude that overall, yes, there is a difference, and it is statistically significant. The next learning objective is visually assess the variability of the body of studies in a meta-analysis. A meta-analysis question framed to include a broad range of patients, interventions, and ways of measuring outcome helps avoid false effects from subgroup analysis, leads to narrow confidence intervals, and increases applicability across a broad range of patients. So that is a good thing. On the other hand, combining the results of diverse studies may violate the starting assumptions of the analysis and lead to false conclusion. That assumption is that across the range of study patients, interventions, and outcomes included in the analysis, the effect of interest is more or less the same. So the solution to this dilemma is to evaluate the extent to which results differ from study to study. That is the variability or heterogeneity of study results. So where does this variability come from? Differences between study results can arise from either differences in the population enrolled, for example, large effects in the more ill patients or smaller in the less ill patients. Also differences in the interventions, for example, if large doses are more effective than small doses. Also differences in the comparators, so smaller effects when standard care is optimal than when it is not, for example. Also study methods, so larger effect in studies with high risk of bias versus those with low risk of bias. So there are different sources of variability between the studies. We can actually visually assess the variability in studies. So studies combining the meta-analysis and depicted in a forest plot will inevitably have some inconsistency or heterogeneity of their point estimates. The question is whether that heterogeneity is sufficiently great to make us uncomfortable with combining results from a group of related studies to generate a single summary effect. In general, we are comfortable with a single summary effect when all studies suggest benefit or all studies suggest harm. A better approach to assessing heterogeneity focuses on the magnitude of the differences in the point estimates of the studies. Large differences in point estimates make clinicians less confident in the pooled estimate. Small differences in the magnitude of point estimates support the underlying assumption that across the range of study patients, interventions, and outcomes included in the meta-analysis, the effect of interest is more or less the same. And lastly, if confidence intervals overlap widely, random error or chance remains a plausible explanation for the differences in the point estimates. When confidence intervals do not overlap, random error becomes an unlikely explanation for differences in apparent treatment effect across studies. So now let's take a look at what all of this actually means. So when visually assessing variability, one must ask two questions. How similar are the point estimates, and to what extent do the confidence intervals overlap? So let's take a look at some examples. So let's take a look at the meta-analysis on the left. So you can see there are 4 studies included in this meta-analysis. So the line of no difference is 1. So we're looking at odds ratio here. So because it's a ratio, crossing 1 would mean no difference. So if it's less than 1 would favor treatment, versus if it's greater than 1 it would favor the control group. So we're comparing 2 groups. So in study 1 you can see that actually in the first 2 studies you can see the results. So the point estimates, which are the circles, as well as the confidence interval, are in favor of the treatment, whereas the second 2 studies are actually in favor of control. And when we do the meta-analysis overall, the results are in favor of the treatment group. So now the question is, if we are visually looking at this, what are we going to find out? So the first thing is that you can see that the point estimates are not in agreement, right? So the first two studies, the circles are in favor of the treatment group, and the second 2 are in favor of the control group. So that shows you that there is extensive heterogeneity by just looking at it. Now let's take a look at the second meta-analysis. So in the second meta-analysis we also have 4 studies, and you can see that in this one all the point estimates pretty much line up. So they're all in favor of treatment. So that's a good thing. So even though none of the studies are statistically significant, so all of them cross 1, but because all of them are pretty much aligned in favor of the treatment, and then when we do pull the results together in the meta-analysis and the overall study is statistically significant, because they all pretty much line up, there is no heterogeneity. So all the studies are pretty similar. So that's a good thing. So in the first meta-analysis, there's extensive heterogeneity because the point estimates don't line up. Whereas in this one, in the second meta-analysis, they all line up and the confidence intervals pretty much overlap. So that's a good thing. There's essentially no heterogeneity between the studies. Now let's take a look at the third meta-analysis. In the third meta-analysis, you can see that we also have 4 studies. Two of the studies, so the first one and the third one, have their point estimate in favor of the treatment group, whereas the second and the fourth group have point estimates in favor of the control group. And overall, um, the results are not statistically significant because they cross one. But now, when you assess heterogeneity, you can see that 2 of the studies have point estimates in favor of treatment group versus the other 2 in favor of control group. But overall, all of them overlap. So if you look at the confidence interval, they pretty much overlap. So that's also a good thing. So you can see, although there is some heterogeneity between the studies because of the point estimates different, but it's not as much heterogeneity as the first meta-analysis. So definitely a lot of heterogeneity in the first meta-analysis, practically no heterogeneity in the second meta-analysis, and there is some minor heterogeneity in the third meta-analysis. So even though the point estimates don't line up, there is overlap between the confidence intervals. So both the point estimates and the confidence interval are important when you visually assess the heterogeneity. Now there are other ways to assess heterogeneity, like statistical tests, and I will talk about those in a little bit. So the next learning objective is interpret statistical tests for heterogeneity in a meta-analysis. Let's take a look at different null hypotheses. So let's say we have 2 groups. Group A is the intervention group, and Group B is the control group. And we're looking at some sort of outcome. So let's say mortality, for example. So for the outcome, there will be some number of events in Group A and the number of events in Group B. Now, the null hypothesis denoted as H0 and the alternate hypothesis as H1. So generally, in a superiority randomized controlled trial, the null hypothesis is that there is no difference between groups, so A equals B. And the alternate hypothesis is there is a difference between the 2 groups, so A is not equal to B. We want to reject the null hypothesis in a superiority study. So reject if p-value is less than alpha, which is usually 5%. So we say there's a statistically significant difference if either the p-value is less than alpha or if the confidence interval does not cross 1 or 0. Now, why 1 or 0? So if your outcome is a ratio, such as a hazard ratio, you're looking at the 2 groups. So the ratio of A to B, if the 2 groups are equal, so the same number in the numerator and the denominator, so A divided by B equals 1. So if the number in the numerator is smaller, so less events in group A, then the ratio is less than 1, so it means A is superior to B. Now if your outcome is a difference, so the difference would be group A minus group B, so for mortality, for example. So if the 2 groups are equal, A minus B would say 0. So if the difference is 0, that means there's no difference. Now if you have less events in group A, then you get a negative number. So less than 0 means A is superior to B. Now our goal in a superiority study is to actually reject the null hypothesis. So we want a p-value of less than 5%. That means there is a difference between the 2 groups. Now, in a meta-analysis, we want to test for heterogeneity. So in a heterogeneity test, the null hypothesis is there is no difference between studies. So all studies are similar or homogeneous. The alternate hypothesis is there are differences between studies or there is heterogeneity. In this case, we do not want to reject the null hypothesis. That is, we want a homogeneous study. So that's why we want the p-value to be greater than 5%. So that's why if your outcome is a ratio, you do not want your confidence interval to cross 1. So if it crosses 1, that means it's not statistically significant. Or if it's a 0, then you don't want the confidence interval to cross 0. That would mean there is no difference or no statistically significant difference. So as I mentioned, the null hypothesis for the test of heterogeneity says that the underlying effect is the same in each of the studies. So the null hypothesis assumes that all of the apparent variability among individual study results is due to chance. There are different tests for heterogeneity. So two of the more common one is the Cochrane Q and one is the Higgins statistic or the I-square statistic. So the Cochrane Q is the most commonly used test for heterogeneity. It generates a probability based on a chi-square distribution that the differences are likely to occur simply by chance. The statisticians may consider different thresholds for the significance level. A conventional threshold of less than 5% or a more conservative threshold of less than 10% can be used. So for for superiority randomized controlled trials, we usually use the 5% as the alpha. So what they're saying is that in a test for heterogeneity, we may actually use 10%. So it's okay to use 10% because we're really looking for heterogeneity or variability. And they will tell you in the study whether they use 5% or 10%. So it depends on the study. So a low p-value, so low means less than either 10% or 5%. For heterogeneity means that random error is an unlikely explanation for the difference in results from study to study. A high p-value, so a high means like greater than 10%. So a high p-value for the test of heterogeneity increases our confidence that the assumption underlying combining studies holds true. So when a meta-analysis includes studies with small sample sizes and a correspondingly small number of events, the test of heterogeneity may not have sufficient power to detect existing heterogeneity. So just like randomized controlled trial, if the study doesn't have enough patients in it, then the study is not powered to find a difference, right? So sometimes when you have a study and there's no statistically significant difference between the two groups, you want to make sure that you had enough patients in the group to find the difference. So in other words, you want to make sure your study is powered to find a difference. The same is true in meta-analysis. So instead of number of patients, we're looking at number of studies. So if a study is underpowered, as in there aren't enough studies in the meta-analysis, then we are not powered to find a significant heterogeneity. So in order to increase the power, the more studies you have in a meta-analysis, then the more power you have to actually find a difference. The next statistical test is the Higgins statistic or the I-squared statistic. It is a preferred alternative approach for evaluating heterogeneity. It focuses on the magnitude of variability rather than statistical significance of variability. When the I-square is 0%, chance provides a satisfactory explanation for the variability in the individual study point estimates, and clinicians can be comfortable with a single summary estimate of treatment effect. As the I-square increases, we become progressively less comfortable with a single summary estimate, and the need to look for explanations of variability other than chance becomes more compelling. Now, it has been suggested that the adjectives low, moderate, and high heterogeneity be assigned to I-square values of 25%, 50%, and 75%. So in general, when you read a study and they calculate the I-square, so if it's less than or equal to 25%, we basically call it a homogeneous, right? And if it's greater than 50%, we say there's significant heterogeneity. And then there's this area between 25 and 50, and it's hard to tell whether it's homogeneous or heterogeneous. So if it's if you have a study that has like 30 per I square of 30%, you just don't know for sure. But if a study has, for example, I square of 60%, then you know for sure there's significant heterogeneity. And if there's a I square of 10%, for example, you know for sure there is homogeneity, or there is no significant heterogeneity. And you want that to be closer to zero. So if it's zero, it's excellent. And here's a um, visual depiction of those numbers that I told you. So if it's I squared is 0%, you have nothing to worry about. If it's closer to 100%, then there's a very basically all the studies are different. So from 50% and higher, we consider the significant heterogeneity. Now, one thing to consider is that if there is heterogeneity, there needs to be explanation on where this comes from. Some argue that in this situation, meta-analysis authors should not combine the results. So, if there is a lot of heterogeneity, then you should just not combine the studies, because that could give you false overall effect. Clinicians and patients, however, do still need a best estimate of the treatment effect to inform their decisions. Pending further research that may explain the differences between results of different studies that address the same question, the summary estimate remains the best estimate of the treatment effect. Although clinicians and patients must use the best estimate to make their decision, substantial unexplained inconsistency between studies appreciably reduces confidence in the summary estimate. The next learning objective is compare fixed effect model versus random effect model for combining results in a meta-analysis. So there are different models for combining data for meta-analysis. The meta-analyst seeking a method to combine primary study results can do so by using either a fixed effect model or a random effect model. In general, and this is the bottom line that you need to know, a fixed effects model is used when heterogeneity is not significant, and a random effects model is used when statistical heterogeneity is present. So, So let's take a look at each one. So the fixed effect model basically considers the set of studies included in the meta-analysis and assumes that there is a single true value underlying all the study results. That is, the assumption is that if all studies were infinitely large and completely free of bias, they would yield identical estimates of the effect. So with the assumption that studies are free of risk of bias, the observed estimates of effect differ from one another only because of random error. This assumes that any differences in the patients enrolled, the way the intervention was administered, and the way the outcome was measured have no impact on the magnitude of effect. The error term of a fixed effect model comes only from within study variation. The model does not consider between study variability in results, or in other words, heterogeneity. So that's why a fixed effect model is used if there is no uh, significant heterogeneity. Now, the random effects model assumes that the studies included are a random sample of a population of studies that address the question posed in the meta-analysis. Because there are inevitably differences in the patients, interventions, and outcomes among studies that address a particular research question, each study estimates a different underlying true effect, and these effects will have a normal distribution. So the pooled estimate in a random effect model is not estimating a single effect of the intervention, but rather the mean effect across the different populations, interventions, and methods of outcome evaluation. The random effect model takes into account both within study variability and between study variability. So that's why it's important to use random effects model if there is significant heterogeneity. So if you are reading a meta-analysis and you find that the studies are heterogeneous, if there is significant heterogeneous, then you want to make sure that they use random effect model rather than fixed effects model. And here's a summary of the differences between the two models. The next learning objective is assess the risk of bias in the body of evidence provided in a review. So there are different types of biases. So there's measurement bias, there's selection bias. Two that are really important when you look at systematic reviews and meta-analysis is the reporting bias and publication bias. So reporting bias is a skew in the availability of data such that observations of a certain kind are more likely to be reported. And publication bias is the tendency for published studies to be systematically different from all completed studies of a question. Published studies are more likely to be positive. I know this is usually because one thing is the editors of journals find positive studies to be more interesting. So for example, positive we mean if the study actually found a difference. So if a study didn't find a difference, usually it's not it's not exciting news. So typically editors may not choose those studies to be published. That's not always the case, but we're saying typically. The other thing is, the people who actually doing the study, if they didn't find what they were looking for, it's likely that they're not actually going to submit it for publication. Whereas if researchers actually found what they were looking for, then they're excited about it, so they will actually submit it for publication. Now here are the more information about reporting bias and publication bias. I let you read those. The consequences of publication and reporting bias can corrupt the body of evidence, usually exaggerating estimates of magnitude of treatment effect. Meta-analyses that fail to identify and include unpublished studies face a risk of presenting overly confident estimates of treatment effectiveness. The risk of publication bias is probably higher for systematic reviews and meta-analyses that are based on small studies. Small studies are more likely to produce non-significant results due to lack of statistical power and are easier to hide. Now, larger studies are not immune either. So sponsors and authors who are not pleased with the results of a study may delay publication or choose to publish their study in a journal with a limited readership or a lower impact factor. Now, in general, there are 4 strategies to address reporting bias. You can either examine whether the smaller studies show bigger effects, for example, use a funnel plot, and I will talk about funnel plots in a little bit. Can reconstruct evidence by restoring the picture after accounting for postulated publication bias, estimate the chances of publication according to the statistical significance level, or examine the evolution of effect size over time as more data appears. Now, funnel plots are basically in a figure that relates the precision of studies included in a meta-analysis to the magnitude of treatment effect. The resulting display should resemble an inverted funnel, and I will show you a picture in a little bit. Such funnel plots should be symmetric. So it's important to think of it as symmetric. Around the point estimate, dominated by the larger trials or the results of the largest trials themselves. Now, a gap or empty area in the funnel suggests that studies have been conducted and not published. Because visual determination of symmetry can be subjective, meta-analysts sometimes apply statistical tests for the symmetry of the funnel. And that statistic test that they use is called the Eggers test. So with the Eggers test is usually it's used to statistically examine the funnel plot for asymmetry. So again, it's always makes it easier if you think of the null hypothesis. So always the null hypothesis means there is no difference, right? So in the Eggers test, we're looking for the symmetry in the funnel plot. So if there's no difference, that means the plot will look symmetric. So the null hypothesis would be that symmetry exists in the funnel plot, with the alternative indicating that asymmetry is present. So in this case, we also do not want to reject the null hypothesis because we want this to be symmetric. We want them to be the same. So because of that, we also are looking for a p-value of greater than 5%. So just like when we looked at the test for heterogeneity, when we wanted the studies to be similar, so we looked for a p-value of greater than 5 or 10%. The same is true in the Eggers test. We want symmetry because asymmetry means there is publication bias. So that's why a p-value greater than 5% is ideal. And here's what the plot looks like. So here's the magnitude of the effect. So let's say this is the line of no difference, and then different studies can find different outcomes, right? So either in favor of one group or the other group, and then overall we want this to look like symmetric. So you can, as you can see, this kind of look. If you draw a line here, so you can draw a line, and this would be, roughly speaking, would this is kind of symmetric. So it kind of looks like a inverted funnel. Now this one, on the other hand, there's no symmetry here. So there's no, if I draw a line here, it goes through, or it's hard to draw a line, right? Because if you draw a line, I'm not sure how to draw the line here to make it, so there's no way to construct uh, a funnel here. So because this is not symmetric, if you just look at it visually, you can say that there's publication bias. So the previous one, it's more symmetric. So there is no publication bias if you look at this funnel plot. And this one, it's hard to make it symmetric, so there is publication bias. The last learning objective is critically appraise systematic reviews and meta-analysis. So one thing to start with is that there is the Prisma statement. So the Prisma statement is the preferred reporting items for systematic reviews and meta-analysis. It's a guideline for reporting systematic reviews and meta-analysis of studies that evaluate healthcare interventions. So it consists of 27 item checklist and a 4-phase flow diagram. You can find the checklist if you go to their website. And it's just a tool that you can use, if you want to, when you're looking at the systematic review and meta-analysis, if you follow the checklist and if they followed these checklists, then you know that it's a good systematic review and meta-analysis. Whereas if they're not following the items on that checklist, then you can, that can be your criticism. You can say that, well, this review did not follow the Prisma guidelines. Another tool that's available is the grade approach. It is one of several systems to rate the quality of evidence. We don't need to go into details, but especially guidelines, because guidelines for let's say for pneumonia, for example, guidelines for pneumonia, because they do a systematic review of the evidence for treatment of pneumonia, they use the grade approach to grade the level of evidence, and they usually come in 4 categories. So there's a high level, there's a moderate, low, or very low. So that's another tool that you can use, and typically systematic reviews use some sort of tools such as grade to evaluate the studies that they have included in the review. So they will tell you, okay, here's the table of all the studies that we have in our systematic review, and then they use the grade system to say they go through different studies, and they say, okay, this study had a high level of confidence, then the next one maybe had moderate. And so that's a really good way of evaluating the evidence that they're putting in their review. Another system is the Cochrane collaboration risk of bias assessment methods. So there are different tools. Depending on the study you're reading, you may come across one of these. Now, how to appraise a systematic review and meta-analysis. So there are 2 things to consider. One is the credibility, and the other is the confidence. So credibility refers to the extent to which the review's design and conduct are likely to have protected against misleading results. Credibility may be undermined by inappropriate eligibility criteria, inadequate literature search, or failure to optimally summarize results. Now, for the confidence, a review with credible methods may leave clinicians with low confidence in effect estimate. Common reasons for lower confidence include high risk of bias of the individual studies, inconsistent results, and small sample size of the body of evidence, leading to imprecise estimate. So when we are appraising systematic reviews, we need to consider both credibility and confidence. And here's how we do it. We ask questions. So there are 7 questions to ask to evaluate the credibility, and 6 questions to ask to rate the confidence in the effect estimates. So the first question is, did the review explicitly address a sensible clinical question, right? So that's really important. So if, depending on um, the review article that you're reading, there needs to be a sensible clinical question. And then the next question to ask is, was the search for the relevant studies exhaustive? So typically, did they tell you what databases that they looked at? Um, you know, uh, that's also important when it comes to publication bias. So if they use a single database, for example, that there's risk for publication bias because they miss some of the studies. And when they look at different databases, that increases the credibility. The next question is, was the risk of bias of the primary studies assessed? So once we go past the publication bias, then there may be bias in the individual study. So it's a matter of, did they have good methodology on those specific studies that are included in the systematic review? Then the next question is, did the review address possible explanations of between study differences in results? So if there is heterogeneity, then the authors need to come up with some explanation why there is variability. Because if they cannot explain it, then they shouldn't do a meta-analysis, right? The next question is, did the review present results that are ready for clinical application? So the bottom line is, we need to, whatever we're finding in the study, it needs to be significant to the clinical practice. So if it's not ready to be applied in the clinic, then it shouldn't be included. Next question is, were selection and assessments of studies reproducible? So it's important to, if you were to do the same study again, you should pretty much come up with similar results. So it's important to have at least 2 people participate in decision regarding, conduction of the systematic review. One thing that you can do statistically is the case statistic. So the most popular approach to dealing with chance agreement is the chance corrected agreement, so statistically determined with kappa or weighted kappa. Another tool is the chance independent agreement of phi. You don't need to know this thing, but you may come across the systematic reviews and they tell you that, like, the numbers for kappa and phi, and what they're trying to tell you is whether, because there were multiple people reviewing studies, they want to tell you if there was agreement between um, the people who were conducting the study. So was there a good agreement between reviewers in selection and assessment of studies? So a kappa of greater than or equal to 0.6 is considered adequate. So if they give you the kappa numbers, it needs to be at least 0.6. The same with phi. So if they do give you phi, it needs to be at least greater than or equal to 0.6. So in general, that's considered adequate agreement between the researchers. Then the next question is, did the review address confidence in effect estimates? So ideally, systematic review authors will explicitly address the risk of bias that can diminish confidence in estimates as well as imprecision. So for example, wide confidence intervals and inconsistency. Um, Now let's go to rating the confidence. So the first question to ask is, how serious is the risk of bias in the body of evidence? So for randomized trials, risk of bias increases if there are problems with the randomization, if patients, caregivers, and study personnel are not blinded, for example, or if a large number of patients are lost to follow-up. Stopping trials early because of a large apparent effect also can exaggerate the treatment effects. Now, in observational study, the main concerns associated with increased risk of bias include inappropriate measurement of exposure and outcome, inadequate statistical adjustment for prognostic imbalance, and loss to follow-up. The next question is, are the results consistent across studies? So how similar are the point estimates? To what extent do the confidence intervals overlap? And statistical tests for heterogeneity. So we covered these in previous slides. The next is, how precise are the results? So, precision is all about the confidence interval. So the narrower the confidence interval, the more precise it is. The wider the confidence interval, the less precise it is. So if the confidence interval is really wide, then you need to consider, with the clinical action differ if the upper or the lower boundaries of the confidence interval represented the truth. So whether it was really close to no difference or really was a huge difference. That's what needs to be considered. The next question is, do the results directly apply to my patient? So that's extremely important, because at the end of the day, if it doesn't apply to your patient, then you can't really use the study. Is there concern about reporting bias? So for reporting bias, we talked about the funnel plot and the exercise that you can use to answer that question. And then the last question is, are there reasons to increase the confidence rating? So the judgment about our confidence in the effect estimates applies not to a single study, but rather a body of evidence. Confidence ratings begin by considering study design. Randomized trials are initially assigned high confidence and observational studies are given low confidence, but a number of factors may modify these initial ratings. So confidence ratings may decrease when there is increased risk of bias. So risk of bias is not good, right? If there's inconsistency, imprecision, indirectness, or concern about publication bias, all of these will decrease confidence. Now, an increase in confidence rating is uncommon, and it mainly occurs when the effect size is large. That concludes this presentation on systematic reviews and meta-analysis.